What's going on, everyone? This is Blake. This is actually going to be our last SI session of exam 3 content. The next tonight we'll be doing a exam review, so I recommend to be there. All right. To kind of start out with, we're going to go into women's common infections, just kind of normal things about the environment of the vagina. pH is going to be less than 4.5. Predominance of lactobacillus, normal wet prep, and we have normal discharge features. All right, we're going to start out talking about the yeast infection. Alrighty. So this is essentially just a fungal infection usually caused by Candida albicans. Risk factors of this are glycosuria, oral contraceptives, and maybe some antibiotics, pregnancy, diabetes, or immunosuppressant drugs. Signs of this will be maybe some vaginal discharge that's got like a cottage cheese-like feature to it. Some, of course, painful intercourse. That's what that would be with dyspareunia. Diagnosis would be a sodium chloride wet mount hyphae. You don't really need to know that, but treatment to this is going to be our over-the-counter management of azole drugs. So butaconazole, nystatin, these drugs here. These kind of depend on a frequency and severity. They can even be combined with an oral or a topical. Some things to prevent this would be the types of underwear they have on, avoiding that tight fit clothing. Hopefully they're not doing any douching, which is where they kind of put like a liquid thing. Like an example of douching would be like spraying some, it's really bad, but it's like spraying Febreze on yourself. Encourage intake of probiotics and yogurt, and encourage improvement of blood sugar control if they are diabetic. All right, so next we have the trichomoniasis. I'm not sure how I said that correctly. Probably didn't. And I'll be honest, I have a different headset on right now, so it feels kind of different and not too sure if it sounds fine because I can't even hear myself, but I'm very used to that. Okay, so trich. The real big thing about this is we have here on the bottom right, it's called a strawberry cervix. That's kind of the what it would look like. Okay, so we have, if you can just read it here, this is kind of a lot, but risk factors of this would be sexually active women, shared facilities or toiletries, and of course, if they're sharing like a wet bathing suit, it's possible but rare. This is going to be, they're going to have the yellow. A good way to summarize this with trich, if you're writing it down, but yellow, green, frothy discharge. Of course, we're going to have those three things next, always, on pretty much all of these. So painful sexual intercourse, painful peeing. Then we have our strawberry cervix here. The reason I have it bolded here on the treatment is because you really don't need to memorize the medication for this. It's going to be the azole again, but with this one, we're going to be making sure that we're treating both partners, okay? Please underline that. That is the main takeaway from this one. They should refrain from sexual intercourse until both are cured, okay? All right, bacterial vaginosis. This is the most prevalent form of vaginal infection related to changes in the normal flora. Risk factors of this are frequent unprotected intercourse, and if they're douching as well. This one is as Harold said, this one's the one that smells. So I have on my notes here. It's got a little fishy odor to it. This is a thin, watery gray, white vaginal discharge. She said it almost looks like Elmo's glue. That's what we have here. This is not an STI, but this is more prevalent in our sexually active women and if they're same-sex couples. This one can cause preterm labor, and we must identify this in our patients and treat early. Alrighty, next we have PID, pelvic inflammatory disease. Okay, with PID, this is commonly called gonorrhea, commonly from gonorrhea or chlamydia. This goes up into their pelvis and causes this PID. Risk age groups would be sexually active adolescents, or self or partner with multiple partners. The reason it says sexually active adolescents is because they're more common to have multiple partners during this age. So that's kind of what it is. It's not that, adolescents are the risk factor, it's just multiple partners. If they have a temp of 101, or if they're vomiting or pregnant, they will be hospitalized. And they risk being infertile with this. Also, since it's already up there, they are also at risk for ectopic pregnancy. The IUD with this does not need to be removed. That was just in my notes, but here we also have signs and symptom of this would be bilateral sharp pain in the lower quadrants, and they're usually associated with fever, discharge, malaise, so they're just not feeling good, and then nausea and vomiting. Alrighty, next we are going to talk about syphilis. This is our third most common reported STI in the United States. This is a chronic infection caused by Treponema pallidum. It's a spirochete. This is commonly acquired through vaginal, oral, or anal sex. Highest group of this would be 15 through 25-year-olds and living in urban environments. These patients should be screened for HIV because usually that's occurrences occurred as well. And then the test that we're going to be doing for this would be the ELISA test, followed by the Western blot test, and that's going to be the HIV test that you guys might have already learned about in MedSurg. We have 3 stages to talk about here. These come in 3 different stages. Okay, so the first one is going to be a painless shrink reappearance 3 to 4 weeks after exposure. It lasts 1 to 5 weeks and then disappears. So it's kind of, you wouldn't really know. The next, at the 6 to 8 weeks, we do have kind of black dots, little things on the soles and palms. This lasts for a little bit and then it'll commonly go away. And it's usually like kind of on the hands, things like that. So these patients, when it goes away, they may think it was just, nothing. And the latent phase appears about 1 year after exposure and may last up to a lifetime. This can be progressive, decimated with neuro and cardiovascular damage as well. Kind of going into a little more information about syphilis. About 1/3 are not bothered by it. 1/3 develop tertiary and 1/3 die from this disease if untreated. Congenital syphilis may be asymptomatic in the first week of life or may be full progression. All right, so we do have that the mucocutaneous lesions may be the only clue, and the diagnosis of this would be the VDRL and RPR are the initial screenings and follow-up success in treatment. Titer should be dropped 4-fold. That's nothing that's too important, but that's just what I have in my notes. The assessment of syphilis, what I have here as well is clients with syphilis will have a positive serologic test, which is the VDRL, okay? If syphilis is untreated during pregnancy, 25% of pregnancies will end possibly in a stillbirth, and 40 to 50% of neonates born to these women will have symptomatic congenital syphilis. Alrighty, and just understand that there's 3 screenings we do at the first prenatal visit, the 3rd trimester, and then at delivery as well. With syphilis, the treatment depends upon the stage. Remember that we are also with this, we're doing the Western blot testing for HIV. When you do a follow-up in 3 months. And then if it's congenital, we need to also be consulted with a pediatrician and check out the CDC for treatment of this. Penicillin is always preferred, and only penicillin is effective to treat both patient and fetus in pregnancy. They will use this even if the patient is allergic. So if the patient's allergic, they're kind of sensitize them slowly. So they might start off with some lower doses, and then just with this kind of scenario, the benefits outweigh the risk. Okay. Alrighty, going in next, we're going to herpes simplex virus. HSV1 is the oral form. HSV2 is the genital form, usually. Transmission is most often with direct contact with the lesions. There is a 2 to 12 day incubation period of this. Here we have 30 million people are affected. We have painful papules, vesicles, ulceration, crusting, and healing. Signs and symptoms would be some burning sensations, itching, painful urine, painful tenderness, especially in females. The primary episode is the worst. Recurrent outbreaks are milder, unless it's HIV or if they're immune compromised. Alrighty, next we have kind of more about the HSV. We have assessment. They may have hay fever. They may have fever, adrenalopathy, viral shedding for 12 days and healing for about 21 days. They may have a prodromal phase, then reoccurrence in the exact same spot. Females suffer more than males due to the worst painful sensation while urinating. The diagnosis of this would be a viral culture if the lesions are still present, and then titers to kind of be determining if this is type 1 or type 2. The treatment of this is there is no cure, so we're just going to minimize the symptoms. Recommended treatment for the first clinical episode would be oral antivirals, acyclovir, just those virs. And then we're going to make sure we're doing some suppressive treatment as well to decrease the partner transmission. Vertical transmission for herpes. Patient may need Zovirax at term to decrease the risk of outbreak and at the time of delivery. If the active lesions are present in labor, they will need a C-section. No cultures needed. History, an exam only. The primary outbreak in pregnancy is most likely to be transmitted to fetus and the neonate due to the lack of protective antibodies. And recurrent outbreaks pose much less fetal risk. Neonate that's affected could be severely disabled due to neurologic effects of the disseminated herpes. Alrighty, and what I have in my little book here, the etiology of herpes is type 1 or type 2. The maternal symptoms of this include vesicles on the genitalia, thighs, and or their butt. It's usually painful. The fetal symptoms include fever, hypothermia, jaundice, seizures, and poor feeding. And about half of the fetuses affected will develop vesicular skin lesions. There is no known cure. The virus can be lethal to the fetus and is transmitted during birth. C-section is indicated if the mother has active lesions at the time of delivery, and antiviral medications such as famciclovir, acyclovir, which is we have up here, and then the it's back over here. That valciclovir as well are still investigated for safe use during pregnancy. All right, next we have human papillovirus, HPV warts. They're also called genital warts. This is a viral transmission that occurs through vaginal, oral, or anal sex. The incubation period for this following exposure is about 3 weeks to 2 years, and the average is about 3 months. The assessment of this would be if it's benign, the milk signs and symptoms would maybe itching, easily bleeding. Cauliflower-like lesions found around the labia, vestibular, pelvic floor, and/or anus. And it feels like lumps are raised, fleshy lesions through the surface. They can resolve spontaneously. The outbreaks can increase in pregnancy, oral contraceptive use, immunosuppression, and trauma. And going into like management of this, we have to use vinegar or TCA to help identify the wart's cause, frosted appearance of the tissue. Do a PAP for cervical dysplasia or cervical or anal rectal cancers. Some lesions can only be found by a colposcopy. The treatment of this would be thorough self-treatment available. Most common treatment is TCA, podophyllin, immunoquid, and home or office-based treatments. You'll have to look at the guidelines. It's not that important for that. Really important though, the transmission here. Pregnancy may worsen HPV outbreaks, can be vertical transmitted, rare, but C-section. Sorry, but C-section is not indicated unless there's massive growth impeding the vaginal delivery. Vertical transmission manifests as laryngeal papillomas in the toddler, and we must warn the mother to report change in cry, which can be months or years later. This can be also indicated sexual abuse in a child if they have like a forced type of sexual abuse. So it should be reported, especially if the mother has no history of genital warts. Kind of more of a PEDS thing there. Alrighty, next is the UTI, also called cystitis. We have a bacterial infection in the bladder. If there's a risk with this, it would be that this can cause preterm labor and it can be asymptomatic. Risk factors of this would be if they're not urinating after intercourse, if they're drinking lots of caffeine, maybe they have high blood glucose levels, if they're retaining urine as well. Dehydration, or if they're just pregnant. Signs and symptoms of this would be the painful urination, fever, suprapubic pain, hematuria, weakness in the body, or if they had a cloudy urine with film, that's very odorous as well. We might do a UA or a cultural insensitivity test as well. The big kind of takeaway as a complication of this would be the pyelonephritis. If the infection travels up in the bladder through the ureters into the kidneys, it would be really, really bad. They can also have that back pain, flank pain, unilaterally, if it has affected one of their kidneys. Okay, changing gears, now let's discuss, and I think is pretty simple here. We're going to be talking about contraception and the different methods available. This table here can really summarize what we're talking about. So I would recommend to pause it here. You can write this down if you would like. Okay. To kind of start out, we have the least effective methods here are the ones that are being used or needing to be used every time that you're having sex. As their barrier methods, or we have some hormonal methods, and then we have the permanent sterilization, or something that's going to last for a few years up here. We have types of different birth control. We have continuous abstinence. That is the only for sure way to prevent pregnancy with a 100%, I guess, success ratio, because it is the most safe, I guess. We have natural family planning method, the rhythm method. That's kind of where they're Well, we're going to talk about it a little bit, but that's kind of where they're evaluating their cycle and knowing which days would be like the safest, which days are, the days that they would want to plan it if they want to go ahead and become pregnant. Barrier methods, we have these different things here. We have a sponge, diaphragm, cervical cap, the shield, the female condom, and of course the male condom. And then going in next, we have some hormonal methods. So these are our usual things that we commonly call the pill. We have the patch, we have the shot injection, we have the vaginal ring, and I'll kind of talk about these, but this is just kind of it summarized here. Next, we have implantable devices, whether it be a rod or an IUD. We have permanent birth control method, which would be a sterilization implant or a surgical sterilization. We also, of course, have our vasectomy that is associated with this as well. And then we even have emergency contraception, which is we call it Plan B, or the morning after pill. And this must be taken within 72 hours at the max. The longer you wait, the least effective it is. So I don't know why, but I saw on Twitter one time, it was like whenever they take it at 71 hours, I was like, that's kind of scary, but it was just some weird meme. Okay, natural family planning, kind of a lot here. If you'd like, you can give that a read. That's what I pulled from our book. But essentially, to kind of bring it all together here, you have to know your cycle and having unprotected sex on the days that you're most fertile. You have to know your cycles, and you have to know the signs of ovulation. So we have like an increased basal body temperature. They might have, they can observe the cervical mucus changes, things like that. But with the BBT, the basal body temperature, there is one thing that can kind of mess up that observation would be, of course, if you just get sick, or maybe you, I mean, it would seem like it'd be really hard to kind of measure. So this one is not really that recommended, but people very well still do it as well. Okay, now we have the kind of ones that everyone kind of understands here. We have the hormonal methods. We have the combined OCP. And here, I highlighted what we have to really big take away from here. We have birth control pills called the pill. This contains estrogen and progestin. This is going to prevent our ovaries from releasing an egg. Contraindication of this would be if they're over 35, if they're smoking, or if they have a history of blood clots or cancer. And kind of keep note that whenever we say the hormones that are associated with this, they're usually going to also associate with kind of the same risks for the contraindications. Okay, so just kind of follow that through on here. You have to wait at least 3 weeks after giving birth to start again in order to prevent DCTs. And of course, if we have the patient that had a C-section, or if they're having high blood pressure, or especially if they smoke, they should definitely wait longer as well. Side effects of this could be dizziness, upset stomach, period changes, mood changes, maybe some weight gain going on, hypertension, blood clots, and then of course the things that are a complication of that, which would be MI, CVA, and of course vision problems. There's also one thing to note as well. We do have what's called the extended cycle pills. So those are kind of the no period pill. I'm not too sure about it, but with that, it's kind of the side effects would be bleeding in between periods, weight gain, and sore breasts. The real one you have to big focus on is this one right here. Okay, next we have what's called the mini pill. The big difference between these two is this mini pill does not have estrogen in it. Okay, this is used primarily by our nursing mothers because it doesn't interfere with their breast milk, and it's also used by women who have medication condition that precludes the use of estrogen component in a combination preparation. So if they have hypertension or any estrogen related side effects. Women must be highly motivated because the pill is taken at the same time every day. and is slightly less effective than our, I'm not sure what the CFC means, but the major problems are amenorrhea, so they're having no more period or irregular bleeding patterns as well. Next one is going to be the patch, called the Ever patch here. You'll see I have it bolded twice. This one is having the same hormones as the combined over-the-counter pill. So we have, well, I guess it's called oral contraceptive pill. This is applied weekly for 3 weeks, followed by a patch-free week, which is where they usually have their period, similar to the period of the month. The skin patch is worn on the lower arm, their butt, the outer arm, or the upper body. Commonly, it's usually put alternating the arms here, what we have on this picture here. It releases the hormones of progesterone and estrogen in the bloodstream to stop the ovaries from releasing eggs in most women. It also can thicken their cervical mucus, which keeps the sperm from joining with the egg. These women should wait 3 weeks after giving birth to begin using birth control that contains both estrogen and progesterone. These methods would increase the risk of dangerous blood clots that could occur after giving birth. Kind of the same thing as well. If they're obese or have high blood pressure, it would wait longer. Next, we have the NuvaRing, also called vaginal ring. This gives off the same hormones. Sorry, team. This is going to be that flexible, soft ring that is inserted by the user for a 3-week period of continuous use, followed by a ring-free week to allow a withdrawal from bleeding. These hormones are absorbed in the vaginal epithelium and result in a steady serum concentration. This would stop the ovaries from releasing eggs again and would thicken that cervical mucus again. It's just a different method, okay? Side effects of this would be everything similar to the combination pill, but this has these symptoms up here. So it can be erosion of the vaginal wall. The ring could mess up. We could have increased vaginal discharge, interference with your coitus, unpleasant odor from that area, maybe a premature discontinuation due to vaginal discomfort as well. All right, next we have the Depo shot. This is going to be still hormonal, but this is going to be an injection. They're going to get this every 3 months. This is not combined. This is only progestin. Okay, so similar to the same hormones as the mini pill. This is going to stop the ovaries from releasing an egg. Side effects of this would be a disturbance of their menstrual cycle. Maybe it could cause depression, acne, weight gain, and loss of bone density. So some of the common things with this is this may reduce their calcium levels. So the FDA has actually kind of warned about using it for anything over 2 years because they can, reduce bone loss. Maybe not reduce bone loss, but increase bone loss without loss of calcium. All right, next we have the implantation method. So we have the rod here, also called Implanon. This releases progestin. This is implanted in the upper arm to prevent pregnancy for 3 years. I don't know why the years is gone. Changes, and this can cause changes in the uterine lining and cervical mucus to prevent sperm from joining an egg. We have the side effects of this would be menstrual irregularity, headaches, weight gain, maybe some breast tenderness and depression as well. And this must be replaced every 3 years. Next, we have the IUD methods here. We have the Mirena, also called Kyleena. The Mirena provides an intrauterine contraception for 5 years, but has been shown to be effective for as long as 7 years. This is like the small T-shaped thing on the bottom here, with a reservoir that releases levonorgestrel over a 24-hour period. This provides a 5-year protection. And this is the one that's usually used when they're allergic to copper, okay? Next, we have the non-hormonal method that does have copper. That's kind of what it is. It provides effective contraception for about 10 years. Doesn't hurt to know with this IUD stuff that the preferred IUD patient is someone who has low risk of STIs, because this does not protect against STIs, okay? They have to have a no history of a PID, and they have to have normal uterine anatomy as well. This one doesn't interact with medications, and cramping can actually occur from 2 to 6 weeks after the insertion. Also, adolescents rarely meet the criteria for this method. So that's just something to note as well. Okay, next we have the barrier methods. The first one here we're going to talk about would be spermicide. And with the barrier methods, they have to be used every single time that these patients are having sexual intercourse. So we have spermicide, which is the chemical barrier preventing pregnancy by the killing of sperm and neutralizing the vaginal secretions. They would have to apply this before every single act. Of course, next we have the male condom. They would have to put it on their penis, roll from the tip to the end of the shaft before vulvar or vaginal contact. So some kind of teachings with this would be that they need to avoid oil-based lubricants, as it can decrease their effectiveness. And the natural kind does not protect against STIs. Also, latex allergy, something to be aware about if their patient has that. Next, I have a female condom, and I have the picture here over here on the left. It fits into the vagina so that the ring fits loosely against the cervix, lines the vagina, I was gonna say vaginal ring, vagina, and partially shields the perineum. And I also read that you don't want to use this at the same time as the male condom. Next we have the diaphragm. And the diaphragm is what I have on the right with the pink right there. This is the steel band that forms a ring and is covered with latex. So when it's inserted, the ring lodges high in the vagina, covering the cervix. The spermicide gel or foam is used before use. Have to get fitted for a cap or diaphragm by a doctor. This must be in place for 6 to 8 hours after having sex. The diaphragm is removed within 24 hours. There's a cap and shield within 48 hours. Next, we have a contraceptive sponge. This sponge contains spermicide, which goes into the vagina and kills the sperm. Okay, next we have these three permanent methods here. There is a sterilization implant, also called a Zero. We have the non-surgical method, in which a device is put into the fallopian tubes to block an egg and sperm from joining. It looks very small. I can see it between those 2 fingers there. This is going to take 3 months to work. So before that kind of kicks in, these patients need to be aware, and this is the teaching thing. You don't want to be, you don't want to have the under impression that it's going to work immediately. Next, we have a surgical sterilization. We have a women's tubal ligation, surgical cut or tied sealed fallopian tubes. This is not reversible, okay? A lot of times patients, if they have any issues with the placenta, they will get this ligation I don't know, just as a preventative for what could happen later. And then we have the male version of this, which would be a vasectomy. This prevents sperm from going into the penis. There is a semen analysis needed to determine that the sperm is gone at 6 months. And then, of course, at 12 months, it's kind of encouraged to check again, just to make sure that it's maintained. These patients will not be sterile until 4 to 6 weeks after that procedure. I also read about 36 ejaculations. And then a second form of contraceptive is needed during that 4 to 6 weeks, okay? This is reversible, but I would imagine it'd be a kind of tricky procedure. But yeah. And then we also, lastly, we have our emergency contraceptive methods. I also call them ring after pill. I'll drink some water. This is going to be used in instances where the woman is concerned about becoming pregnant because of whether it be unprotected intercourse or when their contraceptive method fails. Emergency contraception should be considered an emergency and not be used on a regular basis. So this should not be used as a common birth control method. I would actually be interested in what the effects that would do. Because essentially the pill is just a high release of hormones that would suppress it. This pill has a higher success rate when used within 12 hours, although they do say it can be used up to 72 hours later. Alrighty, that's going to be it for this week. Very short recording. I'm going to go and pause the recording and bring up the QR code because I believe I actually forgot to put it on this PowerPoint here. So I'll do that right now. Alrighty, this is the QR code. If you please sign in. If there's any questions about any of this content, feel free to reach out to myself or Professor Harrell. Just really when it comes to those methods of contraception, understand the hormones, understand the differences between the two, which are permanent, I guess how long they're taking those different methods, things like that, kind of the teaching. If there's anyone that has any questions with those methods as well, one thing that Professor Harrell kind of gave me was there's a website called bedside.org that kind of really summarizes the different methods of contraception as well. That website will have pictures and it has a lot of comparisons as well. Alrighty. And of course we have Yuki here. He's sleeping.